An hour ago, this toddler was screaming, arching his back, fighting every hand that came near him. His parents were exhausted by the noise. Now the room is quiet. He has stopped fighting. He lies still, breathing fast, the skin pulling in between his ribs with each breath, and he barely looks at you. The parents are relieved he has finally settled. You should be alarmed. Because in a sick child, the screaming one is working, and the quiet one may be the emergency. A child who stops fighting is often a child who is running out of reserve. By the end of this, you will read a child's vital signs against their age, spot respiratory distress before the numbers fall, tell croup from the airway emergency you must not touch, and catch dehydration early. This is pediatric nursing. All of it. Let's build it from the ground up. Chapter 1. Not a small adult. Here is the idea that reorganizes all of pediatrics. A child is not a small adult, and the clearest proof is the vital signs. Normal depends entirely on age. The younger the child, the faster the heart rate and the faster the breathing, and the lower the blood pressure. A heart rate of 140 would alarm you in an adult, but in a newborn it is perfectly normal. A blood pressure that looks low for an adult is expected in a toddler. So you never read a child's vitals from memory. You read them against a chart, for their age. Numbers that are normal at one age are an emergency at another. And here is the second half of that idea, and it is the one that catches people. Children have tremendous reserve. When something goes wrong, a child compensates, speeds up the heart, speeds up the breathing, shunts blood to the core, and can hold their blood pressure normal for a long time, looking deceptively stable. And then they do not gently decline like an adult. They fall off a cliff. By the time a child's blood pressure drops, they are already in serious trouble. So in a child, a falling blood pressure is a late and ominous sign. You act on the early signs, the work of breathing and the level of activity, long before the pressure moves. One more consequence of being small. Almost everything is dosed by weight, in kilograms. A medication dose, a fluid bolus, the amount of blood that counts as a big loss. All scaled to how much the child weighs. So the weight is not a formality on a pediatric unit, it is a safety number. And you weigh the child, in kilograms, and you double-check the math. A decimal point in the wrong place is far more dangerous in a 10-kilogram child than in an adult. Our patient is Mateo, 18 months old, brought in by his parents after 3 days of a cold that turned into hard, fast breathing. He weighs 11 kilograms. Right now his heart rate and breathing are fast, but his color is good and he is still reactive. He is compensating. Whether we read him correctly, before he stops, is the whole story. Chapter 2. The Pediatric Assessment. Before you touch a child, you assess them from across the room, and there is a simple frame for it, the Pediatric Assessment Triangle. 3 sides, and you can see all of them from the doorway. First, appearance, how the child looks and acts, alert and interactive, or limp and glassy-eyed. Second, work of breathing, are they using extra effort, retractions, flaring, noises? And third, circulation to the skin, is the color normal, or pale, mottled, or blue? A child who is interactive, breathing easily, and pink is stable, whatever the numbers say. A child who is any combination of limp, working hard, or poorly colored is sick, and the triangle tells you before you ever lay on a hand. Children feel pain and the myth that they do not has done real harm, so you assess it in a way that fits the age. For a young child who cannot rate a number, you watch behavior, and the tool is FLAC, face, legs, activity, cry, and consolability. For a preschooler and up, you use the faces scale, a row of drawn faces from happy to crying, and they point. And for an older child, the 0 to 10 number, just like an adult. Match the tool to the child, believe the behavior, and treat the pain. And 2 ideas that shape everything on a pediatric unit. First, family-centered care. The parents are not visitors, they are part of the care team, and a frightened child is calmer with a parent present, so you keep them together whenever you can. Second, atraumatic care. You minimize fear and pain, do the upsetting procedures away from the bed so the bed stays a safe place, use the parent's lap, and be honest with the child in words they understand. A calm child is easier to assess and easier to treat. Mateo is clinging to his mother, and that is where we keep him, on her lap, because a screaming, struggling toddler breathes worse and tells you less. From across the room, his appearance is still okay, but his work of breathing is clearly increased. The triangle already has one side lit up. That side is the respiratory system, and it is where most pediatric emergencies begin. Chapter 3. Respiratory Distress. Breathing problems are the #1 pediatric emergency, and most codes in children start as respiratory, not cardiac. So the signs of a child working to breathe are the most important thing you will ever learn to see. Retractions, the skin pulling in between and below the ribs as they strain. Nasal flaring, the nostrils widening with each breath. Grunting, a small sound at the end of each breath, the body's own attempt to hold the lungs open, and it is a serious sign. A fast breathing rate. And noises, we will get to which noise means what. A child using all of these is spending enormous energy, and the danger is what happens when they get tired. Why are children so much more vulnerable here? Because everything is smaller and less developed. Their airways are narrow, so a little swelling or mucus that an adult would shrug off can nearly close a child's airway, and resistance to airflow rises steeply as the tube narrows. Their chest muscles tire quickly, so they cannot keep up the hard work of breathing for long. And infants under about 6 months breathe mainly through their nose, so a stuffy nose alone can be a real problem. Small airways, a tiring pump, and nose breathers. That is why a cold becomes an emergency in a child far more easily than in you. Pause. A toddler with a respiratory infection was crying and fighting the exam an hour ago. Now he is quiet and still, his breathing is fast with the skin pulling in between his ribs, and his oxygen saturation has slipped to 90. His parents say he has finally calmed down. Is this better or worse, and what do you do? This is worse, much worse. The quiet is not calm, it is exhaustion, a child who was compensating and is now running out of energy to keep fighting. Combined with the retractions and the falling oxygen, this is a child heading toward respiratory failure. You do not let him rest quietly. You escalate immediately, give oxygen, keep him in a position of comfort, usually upright on a parent, and get help and airway support ready. A tiring child who goes quiet is the classic pediatric trap, and recognizing it is the save. Mateo is still crying, and here is the strange comfort in that. His crying, his fighting, tells you he still has reserve. The moment to worry is the moment he goes quiet, like the child in the cold open. So we treat him now, while he is still working. And we never mistake a tiring child for a calming one. Chapter 4. The Airway Emergencies. 2 upper airway conditions sit side by side, and telling them apart is critical because one you can manage calmly and the other you must not even touch. Croup is a viral swelling of the voice box, common, usually in toddlers. Its signs are a harsh, barking, seal-like cough and a high-pitched sound on breathing in, called stridor, often worse at night, and it usually responds to cool or humidified air and steroids. Epiglottitis is the emergency, a bacterial swelling of the flap above the airway that can close it completely. The child looks toxic, sudden high fever, drooling because it hurts too much to swallow, no cough, and sitting forward in a tripod position to breathe. And the rule that is tested every time. With suspected epiglottitis, you do not put anything in the mouth, no tongue depressor, no throat swab, because it can trigger a complete spasm and total obstruction. You keep the child calm, upright, and you get the airway team. 2 lower airway conditions rounded out. Bronchiolitis, most often from the virus RSV, inflames the smallest airways in infants, giving wheezing, fast breathing, and lots of mucus. And the care is supportive, oxygen, suctioning the nose, and fluids, because there is no quick cure and antibiotics do not help a virus. It spreads easily, so hand hygiene and contact precautions matter. And asthma, where the airways tighten and swell in response to triggers, giving wheezing, cough, and a tight chest. The rescue is a fast-acting bronchodilator, like albuterol, and the long-term control includes inhaled steroids. In a severe asthma attack, watch for the ominous sign, a wheeze that disappears and a chest that goes quiet, because that can mean air is no longer moving. A silent chest in asthma is an emergency, not an improvement. Pause. A child arrives drooling, leaning forward on both hands, refusing to lie back, with a sudden high fever and, notably, no cough. A well-meaning colleague reaches for a tongue depressor to get a look in the throat. What is this, and what must you not do? This is epiglottitis, and you must not put anything into that child's mouth. The drooling, the tripod position, the high fever, and the absence of a cough are the classic picture. Examining the throat with a tongue depressor, or any distress, can spasm and completely close the swollen airway. So you stop your colleague, keep the child calm and upright on the parent, give oxygen if tolerated, and get the airway and surgical team ready to secure the airway in a controlled setting. Hands out of the mouth. That is the whole answer. Mateo does not have epiglottitis, no drooling, no tripod, and he has a cough. What he has is bronchiolitis, RSV, the smallest airways, inflamed and full of mucus. So his care is the supportive bundle. Suction that stuffy nose so this nose breather can move air, give oxygen, and keep him hydrated. Which turns out to be the next problem, because a baby who is breathing this fast and this busy is not drinking. Chapter 5. Dehydration and Fluids. Children dehydrate fast. They have a higher proportion of water, a faster metabolism, and less reserve, so a day of vomiting, diarrhea, fever, or simply being too breathless to drink can tip a small child quickly. And the single most reliable measure of how much fluid a child has lost is the body weight. An acute drop in weight is fluid, so a scale is a diagnostic tool. Alongside it, you read the signs. Capillary refill, press a fingertip and count how long the color takes to return. More than 2 seconds is delayed. In an infant, the fontanelle, the soft spot, sunken means dry. Fewer wet diapers or less urine. Dry lips and mouth. And in severe cases, a fast heart rate and, late, a falling blood pressure. Wait first, then the signs. The treatment is to replace what is lost, and the route depends on how bad it is. For mild to moderate dehydration, the first line is often oral rehydration, small, frequent sips of a balanced rehydration solution, not plain water and not sugary soda, which can make diarrhea worse. For severe dehydration, or a child who cannot keep anything down, you go to intravenous fluids, and monitoring is by output and, again, by weight. And the reassuring counterpart, the best sign that treatment is working is that the child starts making urine again and the weight comes back up. Wet diapers are good news. Pause. An infant has had vomiting and diarrhea for 2 days, and you want the single most reliable way to measure how much fluid she has lost. What is that measure? And name 2 other signs you would check at the bedside. Single most reliable measure is the body weight, compared to a recent weight, because acute weight change is fluid. 2 other bedside signs, any of these, capillary refill time, the fontanelle in an infant, the number of wet diapers, and the moisture of the lips and mouth. Heart rate rises early, and a falling blood pressure is a late, severe sign. Weigh the child first, then read the signs together, and you know it is working when she wets a diaper again. Mateo has been too busy breathing to nurse, and his diapers are drier than yesterday, his lips tacky. He is mildly dehydrated. Because he is working hard to breathe, we are cautious with feeding by mouth, and support his fluids, watching his weight and his diapers. Support the breathing, support the fluids, and let the virus run its course. Now, the other things that bring small children in. Chapter 6. Fever, Seizures, and Infection. Fever in a child is common and, by itself, usually not dangerous. It is a sign the immune system is working. You treat the child's comfort with the right weight-based dose of acetaminophen or ibuprofen, and you teach parents never to give aspirin to a child because of its link to a rare but serious condition, Ray's syndrome. Sometimes a young child's fever triggers a febrile seizure, frightening to watch but usually brief and benign. During any seizure, the priorities are the same. Protect the child from injury, turn them on their side, do not put anything in the mouth, and time it. What matters afterward is finding the source of the fever. Because one source of fever you cannot miss is meningitis, infection of the lining around the brain and spinal cord. The classic picture, fever with a severe headache, a stiff neck, and light hurting the eyes. But in an infant it is sneakier, poor feeding, irritability that gets worse when they are picked up, a high-pitched cry, and a bulging fontanelle. Bacterial meningitis is an emergency, so it is prompt antibiotics and, importantly, droplet precautions, a mask, until it has been treated for a day, because it can spread. Fever plus a stiff neck, or an inconsolable infant with a bulging fontanelle, is not a wait and see. The quiet hero of pediatrics, immunizations, which prevent the very diseases that used to fill these wards. You do not need every date, but know the principles. Vaccines are given on a schedule across infancy and childhood. A mild cold is not a reason to delay them. The common reactions are minor, a sore leg, a low fever, soothed with comfort and the right dose of acetaminophen. And you teach parents that the protection vastly outweighs those brief, minor reactions. Keeping a child on schedule is one of the most protective things a nurse reinforces. Mateo's fever is low, he has no stiff neck, and he consoles when his mother holds him, all reassuring, this is his virus, not meningitis. He is up to date on his shots, which is part of why this is bronchiolitis and not something worse. So, we keep supporting him, and we watch the trend. Meanwhile, he is 18 months old, and that age itself tells us what to watch for next. Chapter 7. Growth and Development. Development marches in a predictable order, and while every child varies, a few anchor milestones are worth carrying, because a child who is far behind them deserves a closer look. Around 2 months, a social smile. Around 6 months, sitting with support and rolling over. Around 9 months to a year, crawling, pulling to stand, and a first word or two. Around 1 year, first steps, and by 15 months or so, walking well. By 2 years, running and 2-word phrases. The pattern is head to toe and center outward, control of the head before the trunk before the legs. You do not memorize a calendar. You carry the anchors, and you notice when a child is well off the pace. 2 frameworks help you meet a child where they are. Erikson stages, the infant is learning trust, so consistency and comfort matter. The toddler is chasing autonomy, so offer simple choices. The preschooler is full of initiative and magical thinking. The school-age child wants to be competent, and the teenager is forming an identity and leans on peers. And play is not a break from care, it is how children cope and communicate, so therapeutic play, letting a child handle a toy stethoscope or give the doll a shot, lowers fear and helps them process what is happening to them. Meet the toddler with choices, the teen with respect for their independence, and every child with play. Mateo, at 18 months, is squarely in the toddler's push for autonomy, which is exactly why he fights every mask and every hand. It is developmentally normal, not just illness. So we work with it, a choice where we can give one, a parent's lap, a familiar toy, his own blanket. The developmental lens turns a battle into cooperation. And that same lens tells us what most endangers a child his age when he is well, which is Chapter 8. Chapter 8. Safety by Age. Here is a sobering fact that shapes pediatric nursing. The leading cause of death in children past infancy is not disease, it is injury, and most of it is preventable. And what threatens a child depends entirely on what they can do. An infant who now rolls and grabs and puts everything in the mouth is at risk of choking and falls, so, small objects and foods like whole grapes and nuts out of reach, safe sleep on the back, and never left alone on a high surface. A toddler who walks and climbs and is curious is at risk of drowning, poisoning, and burns, so, locked cabinets, medicines and cleaners up high and latched, pot handles turned in, and constant supervision near any water. The rule is to childproof for the skills the child has just gained. 2 safety specifics worth locking in. Car seats, the single most effective protection, and the principle is rear-facing for as long as possible in the early years, because it protects the head and neck, then forward-facing, then a booster, graduating by size, not by a rush to the next stage. And poisoning, keep everything hazardous locked and in its original container, and if a poisoning is suspected, the modern first move is to call the Poison Control Center for guidance, not to make the child vomit, because inducing vomiting is no longer recommended and can cause harm. Rear-facing and buckled, and poison control on speed dial. Pause, and select all that apply. Which of these are appropriate safety teachings for the parents of a 9-month-old? Keep small objects and foods like whole grapes out of reach. Place the baby to sleep on the back. Use a rear-facing car seat. Set the home water heater above 140 degrees. And store cleaning products in a low, unlocked cabinet. The appropriate teachings are the first three. Keep small objects and whole grapes out of reach. A 9-month-old mouths everything and can choke. Place the baby to sleep on the back, safe sleep. And use a rear-facing car seat. The other two are dangerous. A water heater above 140 degrees can scald a child in seconds. It should be set lower, around 120. And cleaning products belong locked, up high, never in a low, open cabinet a crawling baby can reach. Childproof for what this baby can now do, which is crawl, grab, and taste the world. When Mateo recovers, his parents will go home to an 18-month-old who climbs, opens drawers, and tastes everything. So part of good discharge teaching is the age-based safety talk, cabinets latched, cleaners and medicines up and locked, water supervised, rear-facing in the car. We treat the illness in front of us, and we prevent the injury that is statistically far more likely to hurt him next. Chapter 9. The child with a chronic illness. Not every child on the unit has a passing illness, and a good example that ties several ideas together is sickle cell disease, an inherited condition where red cells become stiff and sickle-shaped under stress and clog small vessels, cutting off oxygen and causing a pain crisis. The triggers are the things that stress the cells: dehydration, infection, cold, and low oxygen. So the care during a crisis is built to reverse exactly those: generous hydration to unclog the vessels, oxygen, warmth, and real pain control, because these crises are severely painful and the child's pain must be believed and treated. And prevention is teaching the family to keep the child well hydrated, avoid extreme cold, and treat infections early. Hydration, oxygen, warmth, and pain relief. Whatever the diagnosis, being in the hospital is itself hard on a child, in ways that track with their age. A toddler's biggest fear is separation from their parents, so we keep the family close. A preschooler may believe the illness is a punishment for something they did, so we gently correct that magical thinking. A school-age child fears loss of control and bodily harm, so we offer choices and explain procedures. And a teenager fears being different from their peers and losing independence, so we protect their privacy and involve them in decisions. The same admission frightens a 2-year-old and a 15-year-old for completely different reasons, and good care answers the right fear. Mateo's story is the common one, an acute illness in a healthy child, who will recover and go home, but the frame is the same for every child on the unit. Read them against their age, watch the work of breathing and the level of activity. Keep the family close, and prevent the next injury. So, let's put it all together. Chapter 10. Put it together. Every pediatric decision runs through the same 6 questions the next generation NCLEX is built on, with the pediatric lens laid over them. What is happening, and you assess it from the doorway with the triangle, appearance, work of breathing, circulation. Why, which cue matters most, and in a child it is usually the airway and breathing, or the level of activity. What could I do? What do I do first? And did it work? Is the child pinker, breathing easier, making urine? Read the child against their age, and answer the fear as well as the illness. Back to the child from the cold open. The toddler who was screaming and fighting an hour ago, now gone quiet and still, breathing fast, ribs pulling in, barely looking at you, while his parents are relieved he has settled. You had no framework then. Take a moment now. What is happening, and what do you do first? Walk it. What is happening? A child in respiratory distress who has gone from fighting to quiet. That quiet is exhaustion, decompensation, not calm. Why does it matter? Because children compensate until they suddenly cannot, and a tiring child is close to respiratory failure. What do you do first? You do not let him rest, you stimulate and support, high-flow oxygen, keep him upright in a position of comfort on a parent, and you call for help and airway support now. The parents saw calm. You saw a child running out of reserve. That difference is the whole job. If you keep 5 things from this course, keep these. 1. A child is not a small adult. Read every vital sign against the child's age. 2. Children compensate then crash, so a falling blood pressure is a late sign, and a child who goes quiet may be decompensating, not calming. 3. Breathing is the number one emergency. Learn to see retractions, flaring, and grunting. 4. With suspected epiglottitis, drooling in tripod and no cough, you put nothing in the mouth. 5. Weight is the most reliable measure of a child's fluid loss, and wet diapers are the sign that treatment is working. One last one. An 18-month-old with a 2-day respiratory illness is now lethargic, with fast breathing, retractions, and a capillary refill of 4 seconds. His blood pressure is still normal. A new nurse says the blood pressure is fine, so the child must be stable. How do you respond, and what is the priority? Normal blood pressure is falsely reassuring. This child is showing lethargy, increased work of breathing, and a delayed capillary refill of 4 seconds, all signs he is compensating hard. And in a child, a normal blood pressure can persist right up until they crash. So you do not wait for the pressure to fall. The priority is the airway and breathing. Give oxygen, position him upright, and escalate for support now. Reading the child against his age and acting on the early signs is exactly what keeps a compensating child from becoming a coding one. That is pediatric nursing. Not small adults but children, whose normal changes with every year, who hide how sick they are until they cannot, and who tell you the truth in their breathing and their activity long before a number moves. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who worries about the quiet child.